My name is Johannes Schetelik. I'm the head of the cell therapy unit at the Technical University of Dresden, and at the same time, I have the privilege to chair the clinical trials unit within DKMS. The question which you ask about relapse or refractory AML is a complex one, because when we think of residual leukemia after treatment, this is what we may call refractory AML, then this may be encountered at different stages. Beginning after the first course of intensive induction chemotherapy. At that time, it is not a standard definition to define persistent AML at that stage as refractory AML, but at least in our study group, this is already considered as a trigger, especially when other features support going for an allogeneic transplantation, because genetic features plus poor early response indicate that we deal with high-risk acute leukemia. But of course, you can also stretch this and define refractory AML only after having failed 2 courses of intensive induction therapy, or even at the most advanced stage after a patient has failed salvage chemotherapy in a relapse setting. So this is when we call this relapse refractory AML. There are multiple ways to define residual or refractory AML. It is most challenging and most, I would say, also dangerous when morphological leukemia is found after intensive treatment. But of course, residual leukemia can also be detected at much lower levels. And then the question is whether or not residual leukemia at the molecular level should also be considered as refractory. So our approach within the Study Alliance Leukemia, which is the large AML study group I belong to, is to distinguish between patients for whom we aim for curing them with chemotherapy alone, without allogeneic stem cell transplantation. And for those patients, we think that we do need dose-intensive chemotherapy with or without kinase inhibitors in order to improve outcomes, such as midostaurin or other FLT3 inhibitors, which may be approved in the next years in Europe. And then we think of those patients where we early on identify high-risk genetic abnormalities, which render these patients as adverse risk AML according to current standard criteria. And for this group of patients, we try to reduce the amount of chemotherapy which we give prior to conditioning and allogeneic transplantation. The approach is to bring these patients as gently as possible to transplantation, because we are not convinced from the data which suggest that inducing ACR might be beneficial. And of course, if you phrase it a little bit more, let's say, provocative, then one should say that the principle to induce a CR prior to transplantation is conceptual. It's not based by any prospective randomized clinical trial. And we now have the ASAP trial, which showed that at least this inducing ACR didn't improve the prognosis in a significant way. So we are hesitant to deliver a lot of chemotherapy to those patients where we think we anyway need a transplantation. Again, this is a tricky question when we think of contraindications against stem cell transplantation. We are not an aggressive transplant center when it comes to patient age. So above the age of 70 years, we think that individuals have to be assessed very carefully. And of course, there are many patients who are in their 70s and still are in very good performance, have few comorbidities, and thus qualify for allogeneic transplantation. And we think there may be a few patients even above the age of 75 who qualify for transplantation, but very, very few, very, very selected patients. We never performed allogeneic transplantation for a patient above the age of 80, so where we think it is, yeah, this is at least something we respect for today as something we wouldn't think of even. Even below the age of 70, some patients might not qualify for allogeneic transplantation, and of course, some reasons may be related to very aggressive courses of or very many complications related to the initial stage at which leukemia was diagnosed, or complications which occurred during the treatment course of AML. And there may be settings where allogeneic transplantation is not feasible. To give a few examples, when organ failure is prevalent, we don't think of transplantation. So even severe chronic kidney failure is I would say, strong contraindication against transplantation, especially if we deal with severe reduced kidney function. Yeah, in the end, of course, on the other hand, the HCTCI, the so-called hematopoietic cell transplantation comorbidity index, is a measure which helps us assessing patients and partly categorizing them into patients with higher or lower risk for non-relapse mortality especially, but this is not a perfect measure. So many patients with HCTCI scores above 3 are alive after transplantation, also in our hands. And on the other hand, transplantation or this index is definitely far from perfect, and some patients may be very sick and despite having very low formal risk of comorbidity. In the end, our belief is that a good clinician, a good hematologist, should be able to assess the fitness for hematopoietic stem cell transplantation. At least what we recommend is approaching your local transplant center, getting in contact, discussing with the transplant physicians whether or not a patient might be suitable for allogeneic transplantation. Based on our interpretation of the published data and our own data, the AML biology is the foremost predictor of outcome after transplantation. We think it is more important than disease stage and more important than whether or not residual leukemia is present prior to transplantation. And there's, of course, a huge range if you think of just patients with de novo AML, ranging from patients with, for example, a relapsed favorable risk AML, where we do see good responses to salvage chemotherapy with or without venetoclax, but definitely we often deal with chemosensitive disease, and those patients have a very favorable prognosis also after transplantation. The opposite end of the spectrum may be marked by those patients with complex karyotype harboring TP53 mutations. This is a group of patients where we do have a lot of debate. Where we are a little bit more restrictive when it comes to additional comorbidity or additional features which may have an impact on transplant outcome, because per se, this is a group of patients who have to envisage in a way also a high risk of relapse after allogeneic transplantation. And of course, we do need much better maintenance strategies in order to reduce the risk of relapse, especially for this group of patients. The most important thing in order to reduce the risk of relapse, or to reduce the danger associated with the risk of relapse, is to identify relapse as early as possible. And I think from now on, we should aim at detecting at least all relapses which occur in the first 2 years after first-line treatment by molecular markers. So relapse should be detected first at a molecular level so that there is enough time to think about next treatment steps, and patients should not experience morphological relapse anymore. It's easy to say and hard to translate into clinical practice. There are, of course, some patients whom you don't, whom we try to cure with chemotherapy alone, but don't have good markers. But the majority of patients for whom we attempt to cure them with chemotherapy alone are patients who do have markers, either NPM1 mutations or core binding factor translocations, which are very suitable for MRD monitoring. And this is, I think, the most important thing to keep in mind, that we do have to try to monitor those patients tightly so that we identify molecular relapse at an earlier time point. And then, and this is something which, again, our group demonstrated at this year's EBMT, if you transplant those patients without any treatment of the molecular relapse right away, they have an excellent prognosis. And those are, when we think of those patients don't feel anything about their leukemia. They have a perfect blood count, normal blood count, and they are suitable to go directly to transplantation. So I think this is something which we should aim at in order to improve outcomes. It's much more difficult when we think of patients with truly primary refractory disease after 1, 2, or even more lines of intensive salvage chemotherapy. And then, of course, we can think of new drug combinations which may get approval in Europe. Probably they are approved in other parts of the world already, and they are attractive. BCL2 inhibitors are very attractive also for the treatment of acute myeloid leukemia. This is an ongoing field of research. Of course, we have other drugs like menin inhibitors. We have IDH1 and 2 inhibitors. So we will get more drugs into our hands in order to safely bridge patients, and hopefully also to lower the comorbidity associated with treatment. Already now, when we treat patients with FLT3 ITD or TKD, we offer FLT3 inhibitors because we feel that this oral drug treatment is well tolerated and has a very favorable risk-benefit ratio, so that we offer this for all patients who have an improved status for this group of drugs. And the hope is, of course, that we identify treatments with such a favorable risk-benefit profile for more and more patients. just one feature. For example,
Yeah.
when we deal with a relapse of a patient with AML NPM1 mutated with an FLT3 ITD, we offer gilteritinib, but we don't wait until complete remission has been
Mm-hmm.
achieved. So we give it for 3 or 4 weeks. We take the amount of time which we gain by with this treatment to organize transplantation, but the aim is still to go for transplantation as soon as possible, and then to continue this effective drug after transplantation, all building on let's say on data which have been produced by the Admiral and the Morpho trial.